I think I will get started with introductions and so we can start this lunchtime webinar. Welcome everybody. It's really, really wonderful to be here for this lunchtime session. My name is Lucy. I am a arts producer in the CUH Arts team, and I'm really delighted to be joining you all today for this webinar, which is entitled Dance for Medicine for the Elderly. And I'm really, really looking forward to the rich conversation that I know that we're going to have over this lunchtime period together. So I'm going to start by just giving a very, very quick overview into who CUH Arts are. So Annie, if we can have the next slide. So we are the arts team at Cambridge University Hospitals. And we are a team of 6 of us, and we're dedicated to sharing care through creativity. We strive to humanise health, inspire hope, and promote well-being through a diverse programme of live and participatory activities, art commissions and activities. And you can see on the screen I'm showing a couple of snippets from the work that we do. This year we've been celebrating 10 years of our Dance for Health programme, of which this webinar is a really key moment for us to be disseminating what we've learned over the last 10 years, as well as have more of a national conversation about what dance can be in a hospital setting, what it can bring and what the impact is. So just to wrap up, we are really focusing today on dance for medicine for the elderly, and we have a decade's worth of experience in this area. And I'm absolutely delighted to welcome Philippa and CUH's dementia specialist nurse, Catherine Pride, who are going to be sharing all of what we've learned to date, the good, the bad and the ugly, I guess, in terms of working in this space for the last 10 years. I'm equally delighted to welcome Danielle Jones, founder and artistic director of Luminelle, who's going to share their dance practice with people with dementia and Parkinson's disease and working with older people across a number of different hospital settings, but with a particular focus on the National Hospital for Neurology and Neurosurgery, University College London. We've got 2 chairs for this session, aren't we lucky? We're going to be working, I'll be handing over to Angela Conlan, who is the dancer, arts manager for Oxford Health Arts Partnership, Oxford Health NHS, and Paula Haar, who is a clinical nurse specialist in dementia. Both Angela and Paula have worked together across Oxford hospitals and have a really varied practice across producing, facilitating and practically integrating dance into a range of different hospital settings. So I feel like they're the perfect chairs to bring the conversation all together. I'm going to stop talking so that we've got plenty of time for our wonderful speakers today. And I'm going to pass over to Catherine and Philippa, who are going to start by sharing a presentation around our work at CUH. So thank you so much. My face is going to disappear for a little bit now. Thank you.
Good morning, everybody. My name is Catherine. What a privilege to be part of this group. And just a small introduction about myself. So my current role is as a dementia specialist nurse here at Addenbrooke's Hospital, and I've been in post since October last year. However, that's at the end of 43 years since I started my nurse training. So a little bit of experience. Real privilege to have the kind of music connection. It wasn't destined or part of this role specifically, but my journey with Philippa started when I decided to do my master's in dementia studies, and I decided to do a service evaluation of Dance for Health. And consequently, we met. I finished that amidst COVID, a little challenge, but that sort of led to my absolute passion, not just for care of the elderly, for people living with dementia. I have a big musical background. Music's vital and very important in our family, so that's a sort of foundation as well. So musical instruments, big family gatherings, as music is always involved. So in terms of people who are admitted to the hospital, currently there's at least 120 people with a known diagnosis of dementia admitted to Addenbrooke's every month. That doesn't include the people that have fallen through the gaps and not had a formal diagnosis. And anybody with any sort of communications or cognitive impairment, an admission to our hospital, any hospital, is a horrible experience and a real challenge in very many ways. So through this musical movement, we've sort of learned a way of communication and engaging. In terms of how we met, so my research, as I say, was a service evaluation. So not research really, sort of a little tip of the toes into it. But just summarising to see the effects, how wonderful and how we can communicate to people. So currently we're looking at work on Ward G6. Now G6 is a 30-bedded ward, specifically for people who are older than 70. And predominantly the staff are trained specifically for looking after people living with dementia. And with that, 30-bed acute medicine care of the elderly ward comes with lots of different challenges of the environment. It's rarely a quiet moment. The time that we choose, 11 in the morning, tends to work really well, sort of a build up to the doctors have seen everybody. Most people have been, managed to sort of do things in the morning, have their wash, and then we come and just have that little space between then and lunchtime. Where was I going next with that one? So yes. So anyway, working there. So I have the privilege of doing that, and I'm not doing any study on it at the moment, but just reaping the rewards and using music on other wards as well in the same sort of way, just to improve communication. Part of my service evaluation, when I dug it out reluctantly because I wasn't wanting to go back there, I actually found a section which I thought was quite relevant, and it was in relation to the work that Philippa does. And I've written here, working with Philippa has been a great pleasure. Her skills, patience and energy made the group so vibrant, meaningful and effective. Through her, I have learned how to hear people through movement, expressions and emotional response within a group. Thank you, Philippa. And that's really very true in terms of just letting the music do the talking. And we've had some really wonderful and emotional sessions. And I'm a very emotional person, and Philippa will tell you, I have no problem crying in many of these things. And another thing that's really useful for me in this role here, the number of people, as I say, is huge living with dementia. The hospital is a difficult place. Staff education is a vital part of my role. And I've now learned with Philippa's agreement that this is a really fantastic learning environment for many walks of life, physiotherapists, occupational therapists. Many students, they ask if they can walk a day in my shoes. Every day is a different day, but I know for a fact on a Thursday, they absolutely love joining that group. We don't give them anything, no pre-expectations, don't really tell them what we're going to do. So quite often they think they're going to put their Zumba shoes on and dance. And then by the end of it, we sit together, don't we? And we just kind of go over it. And I have never met anyone who's not just been blown away and really very effective in many sensitive and emotional ways of how that group went. I think that's kind of my...
Yeah, that's amazing, Catherine. Thank you. We're going to just bounce between us because Catherine and I are so used to working together. And actually, I met Catherine first when you were doing your MA on Ward C4. And C4 was one of the wards that came under the remit of DME, Department of Medicine for the Elderly. And I know I can recognize a lot of people popping up who do this work, and I'm recognizing people who are interested in beginning this work. One of the main things that you have to understand when you begin bringing a dance practice into an acute hospital setting, which is not only vast, but is also a teaching hospital, is you have to understand what each ward is about, what their goals are, how the different teams work together. C4 was the Department of Medicine for the Elderly. It has now changed. It is now general and more about getting people admitted back out again. But at the time, it was a ward where very elderly, very complex needs were coming into a ward, many bayed. The old-fashioned type hospital, we will have up to 6 patients in one bay and doors that don't close, so open bay, and then every so often you'd have 1 or 2 or 3 separate rooms. So you're talking about a very busy environment. You're talking about an environment where there's a lot of staff coming in, different uniforms, different roles. And for the elderly who are perhaps dealing with a fractured hip, a little bit of cognitive impairment, perhaps the beginnings of depression, a real sense of social isolation. There's so much confusion around who's looking after me, and specifically, what is my role as a patient? How do I navigate this busy, complex ward? And so along come I in the beginning of this attempt to bring the dance practice into CUH. And Catherine was one of the nurses who said, sure, I'll support this. What did that look like? It meant she invited the other staff to maybe just turn the volume down on some of their speech, their language, be a little bit more careful while we were bringing music in. She helped me move the furniture, literally. We were operating beds. Catherine gave me permission to work with patients who perhaps wouldn't have seemed eligible for a dance. They were very frail, or they were fetally curled up in their beds. But with Catherine's understanding of the power of music and my passion for bringing very gentle, very slow, very listening movement into an everyday hospital environment, we were able to affect powerful change, which was then noticed and which was then engaged with, and the program stuck. So at the same time, it's about finding out which of the staff members you can work with so that the practice can be embedded, because it's not a quick thing. It's not a quick fix. Sometimes sessions go very well. Sometimes they're very quiet. Sometimes they're very dynamic. It's not about it being showy and razzmatazz jazz hands. It's about feeling that the patients you've engaged with have got something out of it, that they've been able to show us their non-patient selves, that they've been able to express, that they've been able to understand how they're feeling amidst all the busyness and the chaos. Even simple things, very simple but very powerful, understand where their pain is, understand how they can engage with movements that would allow them to shift their awareness of the pain, maybe even shift the pain. So there's a real physiological engagement that we're undertaking. And at the same time, of course, we are dealing with isolation, people beginning to talk with one another, people beginning to reach out, self-support, support one another, and most importantly, build relationship with the staff who are looking after them. Because if you have danced with a patient in an open, spacious, engaging, joyful way, you are much more ready to look after that patient. So I think a year or so ago, a couple of years ago, maybe even, we started saying we need to work together again, and we need to specifically work with the dementia issue, because as Catherine has made really clear, there's a huge amount of patients coming in with dementia to the ward, and almost half as many who are undiagnosed, but we find them on the wards. And we decided to start a specific group around the dementia patients on G6. G6 is a ward DME, but has a focus on dementia and Parkinson's. So our main difficulty there was that post-COVID, a lot of the spaces that were made available at the beginning of the Dance for Health program, what we call day rooms, have been taken into either more beds or doctor spaces. So we had to really think on our feet. How do we engage with people on the bays? Now, from my previous experience with Catherine, I knew that engaging with people in the bays meant that we could slowly invite, sort of inspire the people who perhaps initially were a little bit reluctant to join in. It's like a ripple effect. So that's where we started. And the pictures that you're seeing are all pretty much on bays. So we go in and very, I'm going to just give you the nuts and bolts of it because that's useful to know. All the patients are in bed.
Yeah.
We have a huge issue in the hospital with pajama paralysis. Patients can stay in bed for a long, long time. The main issue then immediately is deconditioning. And one of the first things Catherine and I do is we open windows, we bring in a breath of fresh air, we begin to actually change how people are sitting, lying down. Catherine's expertise with knowing people's conditions means she can safely bring people sitting up. She'll engage the student nurses. She'll engage everybody. I'm doing the same, following her lead, and just making sure people are as comfortable as they can be in the initial sort of 2, 5, 10 minutes of the session. A session can last 40 to 50 minutes. We actually bring chairs away from the wall. You will go onto these bays and patients are shoved up against the wall into corners. There's curtains. They can't talk to each other if they wanted to. Sometimes they can't even see around the corner. They're really isolated. So that's our first thing. The images that you're looking at right now, that's in the day room, which obviously has the benefit of having a door that closes. It's much more focused. It means we can be quietly listening for the more subtle moments that come up without interruption from the staff. That's something we're going to talk about in a minute. But so on the bays, we then always begin with a lot of introduction. Hello, how do you do? We shake people's hands. We spend time sitting next to them, finding out who they are, where they're from. We're not talking about what's the matter with them. We're talking about what matters to them. Who are they? I'm a dancer. I like music. Do you like music? Oh, no, I don't listen to music at all. Oh, that's okay. Well, let's just see how it goes. So we're generally beginning to bring a different environment into this very busy, acute, noisy space. When we begin the music, as we know, is very powerful. We start with gentle music. We start with open invitations. How does it feel when you receive this music? How does it feel to be listening to this music with us? We're changing the environment. We're not coming in and saying we're going to fix your bowels, your ankle, your fractured hip. We're saying we're interested in who you are and we're going to do something together. Very, very gently, we begin to invite movement, and we always say this is movement that you do in a way that is comfortable. We bring our hands to the engagement, we use touch, and the main issue here is comfort, is reassurance. We are soothing people's anxieties. That's how we begin. What then happens is really improvised each time. So we had one lady on one bay who said she was interested, but she wasn't going to join in. Thank you very much. She made it very clear, arms crossed, slightly dubious, possibly a little bit irritated by the fact that we were shifting things around. By the end of the session, she was not only sitting up, but when we invited, as we always do, what would you like to listen to? What did you used to dance to? What do you dance to? She said, status quo. And we were off. It was literally pretty much head banging. Everybody was vibrant. Everybody was infected by this, whatever you want. Da-da-da-da-da. Feet were going and arms were going. And it was absolutely joyous. We have very quiet moments as well. We might have songs from church, songs from childhood. We might have somebody start to sing a song and we just try and join in as much as possible. But what it does is it brings people into the sense of they are the agents in this creative, improvisational, imaginative process. We're not turning up with answers. We're using the body, the power of music to effect change in a way that's almost seamless, but very, very carefully structured, if I might say. So one of the most important parts I'll just finish with is that we often, always actually, where possible, engage with the family visitors. We say this is the music and movement session. Try not to use the word dance until we're stuck in. And would you like to join in? We have volunteers who now come regularly because they love these sessions. We bring staff in. Catherine's amazing at ensuring that the student nurses are given permission to join in. We do move in a way that makes everybody feel they can join in. It's very important for people to not think, oh my goodness, it's a dance artist. This is beyond what I'm capable of. Quite the reverse. my skills are very much in making sure the dance and the movement is available at a level that works for everybody. Sometimes we get people standing up and waltzing. We had people tap dancing. We do beep-bop-a-lula. People know the words. I'd say really our 3 words are the ones that you mentioned, which I took, which is very vibrant. It's meaningful. These are stories that people are sharing through the music and movement that really bring them back to a sense of themselves. It's infective. The staff will often crowd around the doors, stop their busy days, and just smile. Last week, I rather daringly invited a young healthcare assistant who was singing along to Que Sera Sera. I said, come in and dance. And he did. And the joy in everybody's face, just watching a young man absolutely, unabashedly taking that dance space. That's the work that we're doing here on G6, specifically working with the elderly who are struggling with cognitive impairment. And what we see is inevitably every single time there is a spark, there is a way in, conversations do begin. Sometimes they can be a little bit interrupted, but they are there. The non-verbal communication is there. And I think it absolutely shifts the way their stay in the hospital then continues. So it's a wonderful affair in and of itself, but it carries the potency of being a patient that has more resource to develop their own care, really.
And I would totally be with the shift. I would say the shift in the relationship. So when you're looking after people, quite often it's a bed number. It's that person pushed against the wall. We've just changed. We've transformed that bay, and it transforms and shifts the relationship between the patient and the staff. And they are a person, and they've sung that song, and their daughters joined in, or their husbands joined in. So it's magical.
And it's emotional, as Catherine said. And I think a huge issue for staff is this sense of, in this very difficult work with the elderly, where rehabilitation is not straightforward, recovery is not straightforward, the sense of going home is not straightforward. But the ability to, get that sense of, you can be emotional in this difficult work, and that's not a weakness. It's a strength. Managing it is what you need to do, but to be human, to be present, to be together is the work that we're doing. So, thank you very much.
Thank you. In a nutshell, there we go. That's what we do.
And I'm now going to introduce Danielle, who's going to take us into the next exploration of this work. Hello, Danielle.
Thank you. Hi, everybody. It's so wonderful to be part of this conversation and to follow on from the wonderful work that's being done. And so I am bringing an external perspective and a different hospital environment perspective, some insight into collaboration in a London-based hospital across different ward settings, rehabilitation settings, and to echo some of the things that Philippa and Catherine have said, but also to think maybe slightly outside the box, or differently. And my work as a dance artist has taken a journey through dance in health contexts and through a variety of different iterations. So I want to just first of all introduce that and the work of Luminelle, and then to give you a bit of a couple of case studies, really. My company Luminelle is really focused on bringing the quality artistic experiences that we can develop with people in communities, in health environments, in care settings, in whatever environment we find them, but then looking at how we can retain that quality of experience across an acute hospital ward or an outpatient setting, a public space in a hospital, or a rehabilitation space. And we have over the years developed a number of projects that have given us perspectives that we have garnered and learned through people that we have worked with in these different environments. And so what I wanted to start with is just talking a little bit about our practice. My work has, in the dance and health space, taken me very much into detail, working with people with Parkinson's and with people with dementia, much like Philippa and Catherine were discussing, but also into care settings where there are multiple and co-occurring health conditions. And one of the things that I recognise about the practice of working in dance and health, which really mirrors and echoes what was being said before, is the way that we enrich and humanise the experience of being in an institutional kind of care-based environment, but where the care has become a service provision. And so I'm thinking always in the work that I'm doing about how we can come back to a feeling of care as a relational experience between myself or other artists in my team and the people that we are working with. And so all of that practice really takes a focus on the individual experiences of the people that we work with first. I think one of the things that we do in all of the settings that we come across is we think about how dance is our skill, how dance is our artistic medium, but that first of all, we're all people, and the idea that we need to begin in a practical participatory sense with movement isn't always the first point of contact with people that we come in to work with. So over recent projects that we've been doing, we have been questioning whether there could be a loosening of the idea of participation in dance and what that might look like. So, for example, taking participation as a communication verbally just as much as participation is a physical response to something that we are offering in the moment. And that was one of the key elements of our co-creative project Undercurrent, which I'll talk about in more detail in a moment. But to come back to what I was saying about people and our responsiveness, primarily I would say that the work that I have evolved over time is very much about co-creative, responsive and inclusive practice. And in dance and health, the journey that has been evolving over the last 10 to 15 years in this world of sort of medicalized intervention-based dance practice, there has in a way been a removal of what is inclusive dance work versus what is dance and health. And one of the questions that the team here have been asked a lot is, well, how do I get involved in this kind of work? How do I train to do this? And always I return to a sense that dance in all contexts is about our ways of communicating inclusively with everybody that we come across. And so inclusive, responsive, improvisatory practice that attunes to, the heart of what is happening in front of you. It's about making that accessible no matter where you are. However, obviously, as Philippa and Catherine spoke to, in a hospital environment, there are some really specific challenges in terms of the logistics and the setup of something within this kind of what feels like a bit of an immovable beast sometimes, even ward to ward. There are so many perceived or conceptual barriers that we may face, that may make being inclusive in the way that we want to be feel quite challenging. So I'm going to speak to a little bit of the journey of Luminel's work at the National Hospital for Neurology and Neurosurgery, which is a branch of the UCLH hospitals in London. And going back, because actually I want to talk first of all about our introduction into that practice, into that setting, and to say that the first inroad for us came from a patient, and for that I wanted to highlight that because I think it's really interesting to think about ways of getting involved in working in a hospital, particularly big hospitals where there are many nuts and bolts and many avenues in, and that actually advocacy from patients directly, or from one member of staff who might be a champion for holistic approaches to rehab, can be all you need. And so I was contacted by one of the neurological research physiotherapists at the National Hospital, and he had a patient who had mentioned dance and was really interested in being part of a project that involved dance. And I had been doing many years of work previously anyway in dance for Parkinson's, and so the conversation developed from there, and we decided that a dance program for people with Parkinson's would be possible. And we looked at the neurological rehabilitation unit within the NHNN main building. And so to paint that picture, NHNN has many wards for neurological health, for acute specialist wards through to neurological rehabilitation wards, trauma wards, etc. And we were based in what was called the gym space. And this is a very old building and has this beautiful big high windows. And the gym was in, I'm trying to think how I could describe it in terms of size, probably like a small, I don't know, swimming pool. 30, no, that's too big. I can't imagine like the size of it, but it was a very big, very bright space, but very, very cluttered with all of the rehabilitation equipment, gym equipment, etc. So we decided that this would be the right space for the group. And actually, because we were looking at working particularly with people with Parkinson's, and because this was the NIU, we had the NIU ward on the other side of the building, we also decided to make this an outpatient project as well. So there was a collaboration between people coming in as outpatients to the sessions and people coming across from the NIU ward for the sessions as well. So that program ran for a year and a half regularly in the neuro rehab unit in the gym, and we had a number of sort of projects that we did with the dancers. And one of the things that was really valuable about that was that we had a kind of collaboration with the rest of what is a large community of artists and organisations who run projects and classes for people with Parkinson's across the country. It's a huge movement in terms of community practice. But this was a project that meant that we could bring that connection to a large outside community of dance into the hospital space. We delivered a service level evaluation and research project, which had a kind of a mixed methods approach. And so Ben Bear, who was the neurophysiotherapy partner, did a number of physical measurements. And then we also conducted regular focus group discussions. And we presented these findings later in 2019 at a seminar session. And one of the key things that came out from this was just how much the physical measurement of success, quote, success, for a project of this kind, it doesn't give the whole picture in terms of the holistic well-being and the benefits that come for people who are coming into a session like this for rehabilitation. And so, one of the things we wanted to talk about really was just how much further we need to go in this field to address the benefits from a self-significance and a sort of a self-identity and efficacy perspective. And for people with Parkinson's, particularly because this was what this project was about, to talk a bit about how identity as a patient versus identity as a person, as a whole person, could be drawn out much more in the way that we evaluate and research these kinds of projects. And I'm not going to talk about that any further, although I would love to if we have more time later if there are questions. But I think what I'm really interested in is going sort of beyond what is a medicalized approach to designing projects for a particular cohort of people, and looking instead at how we can bring creative projects to the hospitals as a whole, and look at hospitals as an ecosystem where a co-creation of work could happen across multiple settings with multiple groups of people. And I think that's something that we could demonstrate the value of how inclusive practice can be tailored and suited across anybody that we're coming across in a particular setting. And I'm going to move on now to talking about the work that we did in the acute stroke ward at National Hospital for Neurology and Neurosurgery, the David Ferrier ward, which you can see images of in the scrolling slides here. So the learning that we did with NHNN, and also we were really well supported by Arts and Heritage at UCLH. Guy Noble, who's the director of Arts and Heritage, was really keen to continue to support the development of our work. And the timing of what I'm talking about here is kind of across COVID. So we had the project with people with Parkinson's in the National Hospital up to the COVID pandemic. And we weren't able to return to that model of bringing outpatients and ward patients together in rehab space because of the restrictions, the clinical restrictions associated with COVID. But we had learned so much about working in the hospital, and we wanted to look at how we could re-establish the artistic content that we were developing in the hospital wards directly. And so we devised our project Undercurrent to go into the David Ferrier ward. And still with the ripple effect of COVID, we were having to take, and you can see because there's mask wearing in these pictures, we were having to take a really careful approach to starting this project in kind of a slow phased way. But what this project was really wanting to highlight was something I mentioned earlier about the participation in dance in health projects within hospitals not needing to be led by the idea that every person in the space has to physically join in. Philippe and Catherine earlier were talking about that, going into ward and experiencing a lot of, I want to say that's kind of feeling of self-protection. People in that kind of fetal position, in beds, dark rooms, curtains closed, and that sense that these spaces are really impenetrable and that the environment has been created so as to protect people from everything that goes around on the outside. Because it's so busy and bright and noisy, people are doing the best thing that they can to envelop themselves and create a nervous system kind of blanket for themselves. And I didn't want to go into a ward like that and start trying to set up a kind of a typical space for participation by bringing people out of those protected beds and bringing people into kind of like seated setup, or even trying to get them into another room, for example. So instead, we really wanted to gently introduce the artistic practice of music and movement making around people and alongside people, and to bring them on a gentle journey with us into a co-creation. And actually what our intention was to create alongside the patients a performance that they would be part of and experience in that ward, and their contributions, whether that be verbal, whether that be just some eye contact and eye movement, whether that be them telling us a story or them showing us something that is, next to them in the bed, or whether that actually be them wanting to dance with us. However they wanted to contribute, those stories and those experiences that we have with people would be collected and sort of interpreted by the dancers that I worked with, and then turned into a performance with patients. And I'm really conscious of time, so I'm just going to quickly summarize how that project evolved. But essentially, we started very much with a pilot to see how this would work, and we spent a lot of time on the in the ward. There were 5 bays, and so each day that we were there, we tried to connect with every bay and with as many people as possible. And so each day we were in the ward, in the hospital for a whole day. As you can see from the imagery, that meant that we had a slightly bigger team than might be typical for a project like this, because actually we wanted to connect with everyone in the ways that felt sensible and comfortable for them. And I think it's really important to highlight in the sort of the logistics of this project, we were really conscious of the emotional and self the support that would be needed for the artists for themselves, because of this being a particularly acute space and there being, the potential for emergencies arising. And I was really conscious of them having the opportunity to download what they'd seen and been part of each time they were there. And so to have a wider team to share experiences and to really engage in reflective practice was really important as well. So we have Luminel's project always involved live vocal accompaniment. So the vocalist was on the ward as well. Yeah, there's some pictures. Yeah, so the vocalist was on the ward. The responsiveness then meant that at any given moment, a dancer in in one of the bays at one end of the ward could be having a conversation with somebody in their bed, whilst our vocalist and another dancer could be at the other end of the ward. An improvisatory jam could have built up. We also were able to respond with the same enthusiasm to any improvisation that came up with the staff members as well. And you'll see that on the Padlet as well, that there's an evaluation report that we've put up on there that just demonstrates a little bit more of what the staff impact was, because for us initially that wasn't one of the main focuses of our evaluation, but it was one of the main outcomes, is just recognizing how staff were impacted by seeing patients in different ways, and by also having the environment that they work in enriched in the way that we were able to do so. And the project lasted for an 8-week. So we did a pilot, and then we did an 8-week project where across 8 weeks we were in the ward for a full day, really building and drawing on the stories and experiences of the patients that we met.
Oh, good afternoon, everybody. Thank you, Danielle, and thank you to Philippa and Catherine. Really excited to be part of your celebration today. So I was just going to start by introducing myself, and also Paula, who's my co-chair. So I'm Angela Conlon, and I'm the project lead for Oxford Health Arts Partnership, which runs the Creative Health Service for Oxford Health NHS Foundation Trust. So there's 3 of us. We work across all art forms, and also through gardening and horticulture. And my journey actually started at one community hospital where I first met Paula, where I was the dance artist in residence. And that was back in 2017, and my role has grown significantly since then. I do much less dancing and much more project management. And Paula, I'll let you introduce yourself.
Hello, everybody. Yes, I'm Paula Hart. I'm currently a senior lay nurse for safeguarding adults, but I'm a clinical nurse specialist with working with people with dementia, and that's my background. As Angela said, we met, it seems like a long time ago now, Angela, but we came together and we set up a programme of art very similar to what we've been hearing today. So thank you so much. It's been so lovely to hear both presentations and to hear the really great work that's been happening in Cambridge hospitals. So that's a big thank you from me, and I'm sure we have more to say as we go along the session.
So I was just going to touch upon some of the evidence that's out there. So what has helped me develop in my role has been to kind of draw upon some of the evidence, and we have got a couple of slides for this. So firstly, the Creative Health report, which came out in 2017, the year I started working in hospitals. And this was an absolute godsend at the time, because we were able to really draw upon some of the evidence to keep my post keep me in post, because the first year was dependent on some of the evidence that we were gathering, which really aligned with the evidence that came out in this report. The report has recently been reviewed, and I've just pulled out here on this slide, which we can share later, I'm sure, some of the particular bits that relate to dance and to older people. So there's evidence in there around cancer, dementia, stroke, Parkinson's, but also equally around stress, anxiety, and mood. One of the projects that we've worked on recently, we've looked at how patients' mood changes during a session, whether it's art or dance. And we found a 224% mood increase during our study, which we worked with the University of Oxford on, which is quite significant. I don't know if you've got anything to add to this slide, Paula.
I think what we've also found, and it's more anecdotal evidence rather than kind of actually specific research-based evidence, but we had some anecdotal evidence around patients also requesting less pain medication during and following kind of dance activities and activities in general on the ward. The responses we've had from family members, etc. And I think it's just really given us the ability to keep driving forward the need and the advocating for these activities, both from within the trust and outside our trust for the benefit of our patients, really. So when this kind of research paper was published back in 2017, that really was something for us to cling on to, and it's something that we were able to share with our trust as like, this is something that's really needed. It's valued. There's evidence here to back up what we were doing, really. We weren't just sat in the day room or at patients' bedside having a nice time, which we were, but there was actually a reason and a rationale behind it as well. And it goes to be for the benefit and the well-being of the patients and the staff as well.
And if we could have the next slide, please. So a few years after that, in 2019, this report, so scoping review by Daisy Fancourt for the World Health Organization, really kind of pulled out some of the evidence from across the world that people were finding with different art forms. I've also pulled out some of the things that are kind of relative to dance. But the quote that I absolutely loved and is really relevant to today is here in the top right-hand corner, that a therapeutic creative environment extends beyond the elimination of boredom. And we get that quite a lot in terms of, this is a great project. It's nice to have, the patients are, get bored. So it's nice to have for their boredom. But actually, it's so much more. And I know that from looking through the list of people who have joined us today, I'm sure you all agree that dance can be so much more. So if we go to the next slide, so just kind of pulling on that evidence and also the anecdotal evidence that we've had around pain. This is a research project that we are just about to launch at Oxford Health. It's actually out in the community. We're going to be working with housebound older patients who have just finished with the district nurses. But what's key to kind of some of the things that have come up today is that we are particularly going to be looking at perception of pain before and after a dance session in an older patient's home. So this is one that I can probably talk about maybe next year because we haven't started it yet. I think, Paula, you had, we were going to ask a couple of questions ourselves to the other panellists now. And I think Paula's going to kick us off with the first question.
I'd like to firstly thank both presentations were lovely. And it was I feel really blessed to be able to, to be able to sit in and hear, all about the great work you've done. I think one of the things I'd like to know is how are you measuring the impact of what you're doing, and what is that telling you, and how are you using that impact?
Okay, thank you, Paula. Yes, this is the $1 million question. So we received the Dance for Health program here at CUH received 2 years of funding from the Dunhill organisation to do an evaluation program, which was carried out by ARU Health specialists. In a crux, the problem is the evaluation tools needed to evaluate this work have not been created yet. We are
borrowing from other very sturdy, very robust and interesting and helpful evaluation tools, but it's not really, there's work to be done on how to integrate the physical, the mental, the psychological. It's frustrating. I've got a lot of colleagues. This is exactly what we're talking about. So the great business of collaborating with the staff here means that we need to really understand what makes the NHS tick on a day-to-day basis. So having a project is wonderful. But if you really want a program that allows you to develop the work and embed it on the wards so that it's actually a regular integrated practice. So you have an occupational therapist, a physiotherapist, you have the falls coordinator, you have the dementia specialist, you have a dance artist. It's part of the package. For that to work, we need to do some work together to build the best kind of evidence. What are we measuring? So one of the measurement tools we used in that evaluation was around physical ability. Can people get out of wheelchairs? Pointless. That's not what you're looking for. You're not looking to see whether people can get out of wheelchairs. You're looking to see what physical change has been affected. So there's a lot of work to be done on this. It's the old issue of anecdotal, qualitative evidence as opposed to quantitative evidence. We certainly can show that there's pain reduction, there's better nutrition, people are sleeping better, there's better health outcomes, but how you put those into numbers and boxes and ticks in order to get more money, let alone actually show that the work is effective, there needs to be a huge shift in thinking. I don't know if you want to speak to that a bit, Danielle, or...
Yeah, nothing to add. I mean, I struggled with that with my service evaluation. I knew how wonderful it was, but it's really hard to translate that, short of just showing anecdotal video evidence for the whole of my master's dissertation, which would be perfect.
Yeah, I think I couldn't agree more, really, in terms of, to integrate practice, artistic practice into health settings. For me, I feel that they at least need to be talking the same language, and it's so challenging to find ways of talking about the arts in the language that is necessary, both for commissioning and for fundraising. And what you just said there, Philippe, about it feeling we've done this, but it's just pointless. I find that feeling so frustrating. So what we've done is on a much smaller scale, in terms of budget and in terms of length of the projects that we've done. But we were only able to do the mixed methods research into the Parkinson's work because we were working directly with colleagues who gave their time within their role as because Ben Bear, who I was working with at the time, was a research physiotherapist, so he used his time in order to do that with me. And then for our project in the acute stroke ward, we were able to get the funding to bring in an external evaluator, Emily Bradfield, who's actually here in this session today, and work together with her to design the evaluation. But it's an evaluation, it's not a piece of research, because that would have taken so much more in terms of funding, in terms of the NHS ethics process, etc. And I've had experiences where we've gone through the whole process of ethics, only to then, have the project rejected at various stages. So, yeah, I am essentially just echoing what you say.
I mean, the difficulty with research is if you're going to do research, you have to have a group that's not receiving the work. And that's not really part of what the Dance for Health program is about. But certainly there are a lot, it's all of it's important. And there is a lot of work in museums. I mean, funny you mentioned Emily Bradfield. I also work with Emily Bradfield. And there are ways of researching around museum culture that are we have got tools, but they don't quite address the dance element of it yet, but we're getting there. We're absolutely getting there. We're getting closer. And I think also there's a lot more understanding and tolerance for the evidencing of this work to be more qualitative, participatory. You know, how do we take note of this? But that's a big question. Yeah, we're all keen to answer that one, I'm sure. Thanks, Paula.
You've identified kind of some gaps there with the tools used to measure the impact of what you're doing. In terms of taking that knowledge and experience forward, what do you think might your next steps be?
Absolutely, it's about setting up training. I think what's really clear for a long time, I've been working in dance and health for 30 years, people find their own way to doing this work. The difficulty of getting students onto boards to understand, what Danielle's group have established there, the stroke acute ward, the nuances of that it's been very difficult. So training, specifically in this role that I'm talking about here today in this webinar, training for people understanding how to bring dance work in all its aspects. It can be performative, it can be residential, it can be pilots, all of that. It's a wide continuum, but what's actual skills do you actually need to actually be able to stay on a ward and deliver the work amongst everything else that's going on that makes it significant and meaningful. So yeah, training.
And I think just on a very local level, what comes to mind as I'm sitting here is just the stakeholders. A lot of them probably don't actually know what happened. So I'm actually just sitting here and there's a couple of invitations for the chief medical nurse and deputy chief nurse who actually I would love to invite to one of the groups. And that's learning from the way that the students appreciate it, come in with an open mind and go, wow. And that does translate in terms of just very small uses of music, one-to-one care with people who are really distressed and get the phone out and playing music, so that link is huge as well. So it's kind of branching out just as a music, sort of power of music, really. So it's undercurrents. But I think small things, I like that. We can't do the big one. I can't come up with a tool. I tried that.
That kind of brings me on to the next question, really. In terms of artist training, what kind of skills and what training do you think dance artists need if we've got people listening who have never worked in a hospital before? So Danielle, shall I come to you first?
Yeah, in response to that and also the previous question, my initial reaction is I would be interested in and I'd be advocating for affecting change in people's perspectives on what research and what training needs to look like for artists working in these settings. I think Sarah Houston's point that she's put on the chat here about advocating for people to really press forward with qualitative methods and participatory mixed methods approaches is where I sit in terms of looking ahead and also in terms of training, what I would consider to be important about training. So I'm particularly interested, for example, as an artist in sort of more auto-ethnographic approaches to sharing the perspectives of these projects. And for artists like myself and people who are interested in getting into this work to learn from a reflective practice perspective how people like myself work, but also how that kind of translates into their already embodied knowledge as skilled dance practitioners, and thinking about the ways that we could maybe break down a little bit this idea that you have to sort of have a specific set of tick the box skills for this particular setting or this particular patient group, and instead really looking at that kind of the ecosystem of skills that exist in dance practice as a whole. And because one of my concerns is that people think that they have to shift their ways of delivering when in fact that I worry that takes away the confidence and agency of brilliant practitioners out there who could be implementing this work now. And more, I feel like we could offer bridges between NHS or health partners and artists, and really kind of that idea of that relationship building and logistics building is actually really important part of how people get this work going, which is something that Angela, you and I have talked about, the logistics of just setting up a project, getting the right connections, getting the admin and producing support, getting the ID checks done and the honorary contracts done, etc. Those things, and then people are on the roll into developing their work in collaboration with the people that they meet in the hospital.
I think, Danielle, when you were talking about the very nuanced work that one of your dance teams did, absolutely, the vibrancy doesn't mean it has to be loud and jazz hands. It is a practice and it is a continuum, and you are very much, as a dance artist, adjusting. It's about adaptability, the ability to listen, to bring that creative studio practice. You don't know what's going to come. So it's a lot around that, and that is not a very easy thing to teach. I've done a lot of teaching at dance schools. It's not easy, but it's exciting. It's exciting to think that we can build more dance artists, more dance practitioners, somatic practitioners working in a hospital setting, because it's so incredibly effective. It works. I'm working with babies to 99-year-olds, and it works on all the wards. As you said again, Danielle, different patients don't need tick boxes. It needs a practice, an understanding. Yeah.
Yes.
So I've got one more question that I'd like to appeal to both presenters if possible. When working with people with a cognitive impairment or dementia, what's been your biggest observation? We've heard some lovely stories this afternoon, and I'd like to know what your biggest observation has, what your takeaway, what motivates you to keep going. Is there a particular story?
The stories come, Paula. That's a really lovely, lovely question. Thank you. I'm looking at Catherine, and it's safety. People feeling safe, whether they're walking, trying to get out, whether they're sitting quietly. It's just a sense that somehow our presence brings them a sense of safety and a little bit of trust, and think just that, just a bit of spaciousness, somewhere to just breathe and be supported, be heard.
That's the first point. And their own space. And quite often we find not only we go back to the, sort of isolated bit, not knowing that there's somebody next to them, everything like that, or actually move them into a space that we then create. And communication for me is massive. And the example, even literally just last week, a lady who was very restless and she just didn't want to wear anything, and she just constantly was doing that. And I just spent the whole session just literally sitting with her. And then it was one song we played, and I think it was Que Sera, and all her movements stopped, and she just looked. And we both looked at each other and we thought, we've just touched something there. It stopped and it connected, and she was suddenly connected and part of that space. And that, to me, the communication and the connection is huge. And sometimes that's the first time they've had a connection, a human connection all day, other than a nurse coming to give tablets or somebody to help them wash or the physio working with them. It's a human connection.
Thank you for that question, Paula.
You sat earlier around the lady who enjoyed status quo, and then the rest of the ward being impacted by status quo. That's going to be my takeaway.
This is shit.
Daniela, did you have something you wanted to add?
No, it's just I was thinking about this wasn't in the hospital. It was in a care home working with people with dementia. I was thinking about the major takeaway being how much spaciousness is possible and how much creativity can come from just offering spaciousness for people. And I think not expecting or not needing for there to be a formula for delivering a session for people, and allowing that responsive and improvised practice to really blossom. Philippe is right, it does take a lot of skill and nuanced sort of attention. And what you're talking about in terms of safety, I think, is to do with sort of nervous system regulation, and the theory of sort of holding space for people. And holding space requires a level of sophisticated nervous system regulation on the part of the artist, as well, in my opinion. And I've been really interested in this and kind of polyvagal theory in general in my recent practice. So I think that those two things combined, that idea of anchoring yourself in order to anchor others in a sense of safety, and then give spaciousness for things to evolve, and then things really, really blossom. So it's not, I'm not giving you a specific thing, but I think that is the kind of nuance of the skills required in those cases.